Dr. Alsati, are you here?
Yes, I am.
Hi.
Hello. How are you guys doing?
Good. Thanks for joining.
Thank you.
So we will wait for another minute or so, and let me
Yeah.
message in the group as well.
Sounds good. The weekend. So right now it is 1 o'clock Pacific time. The weekends are gonna be like 5 a.m. my time.
Oh yeah.
I know it's gonna be probably challenging. I'll try my best to join, but maybe like an hour after.
I can postpone the session. Tell me when you will be available.
No, it's fine. I mean, I can do a 7 a.m. instead of a 5 a.m. So
Okay.
just for the GI, I'm just letting you know, like just for now for the GI, if you guys want me to be involved in the GI sessions this week.
Right, definitely I want you to be involved. And you being here is kind of a big boon for us.
Oh.
So 7 a.m. would be like 10 a.m. Eastern time, I think.
Yeah.
And we can start at 10 a.m. So I will post in the group that we are going to have the sessions from 10 a.m. for the weekend.
And okay? How long are they, the sessions?
Till when are you available?
It's just like I have to take my boys to soccer, so maybe a couple of hours. Does that work?
Yeah. If we are doing it like over the weekdays more often, then probably we'll be able to finish in a couple of hours. We'll see about that.
Okay, so let's take it day by day. If this Saturday I'm available from 7 to 9, that's fine.
Okay, cool. Okay, let's do that. All right. Okay. So let's get started. So we are doing the Kurtz notes again, and amongst them we are doing this third one. If you want to download and start in your own computer, medication injury. And, all right. So medication injury in the GIT, and I would suggest that just be chatty and put your inputs in there, especially you, Dr. Alsati, and if you have anything to add or tell or important points, okay? All right, so non-specific injury, pill esophagitis. Pill retained in the esophagus, not enough water or laying supine, caustic or osmotic injury, often elderly women. There will be odynophagia, retrosternal pain, strictures, perforation at the site of aortic arch, that is in the mid-esophagus, and offenders are antibiotics, NSAIDs, iron, and bisphosphonates. So there you'll see the ulceration, acute inflammation, and granulation tissue, and then polarizable crystalline material or pill fragments will be seen. Coming to reactive chemical gastropathy, so this foveolar hyperplasia with corkscrew glands and mucin depletion, edema, inflammatory cells. So, and then colitis, say directly come to the patterns of colitis. So eosinophilic colitis, there are certain drugs listed. Lymphocytic or collagenous colitis, certain drugs. And then focal active colitis, ischemic colitis, interleukin and so forth. Apoptotic colitis, bowel prep effect would be apoptotic, that's important. And mycophenolate. Okay, checkpoint inhibitor will be apoptotic. Pseudomembranous can be NSAIDs and antibiotic associated Clostridium difficile. And neutropenic would be chemotherapy. More specific drug patterns. So for NSAIDs, do you mention in your reports like specifically as to do you check what kind of drugs they are getting, or like based on what you see, do you specifically say that it is NSAID related or something?
Yeah, so pretty much NSAIDs can do a lot of things. When I look for drug history, I look for more of let's say the patient, I see a lot of apoptosis and stuff. That's when I pull up the patient's history, try to see if he's on, 5-fluorouracil or mycophenolate, because I just want my report to be more powerful, that I looked into that patient's history. I know that what I see here is probably not an infection-related colitis. It's probably because of his drugs. And I will put the clinician's mind to ease that what symptoms he's having is related to the drug he's taking. NSAIDs can do a lot of things all over the place. And yes, I will call NSAID-related injury, especially when I see it in the ileum and the stomach. That's the two that I confidently can write that these findings are of an NSAID related. Colon, I can't really tell most of the time, but it could be any other type of drugs. But if I want to call it NSAID related injury, it's either the gastric or the of terminal ileum.
And what are the features that you look for?
You'll have a lot of activity, active inflammation, ulceration, erosion. And you also might have a lot of reactive lymphoid follicles in the terminal ileum as well. It's more exuberant than the regular normal histology. And in the stomach, if I saw some reactive gastropathy features, patient doesn't have, like the clinician doesn't call it like he didn't see any bile or anything, I will call this reactive gastropathy, most consistent with drug-induced injury. I will open the drug, most commonly NSAID-related injury, and then I'll move on. So it's generic, but if you want to write the word NSAID, you should be more comfortable writing it in a gastric or in a terminal ileum rather than random colon.
Right. How often do you see acute inflammation in the stomach in case of NSAIDs?
No, I can't really just call it NSAID related in active inflammation of the stomach. If when I see focal active inflammation of the stomach, yes, it could be NSAIDs, but also I want to see some chronicity. But for when I see focal active colitis in the gastric mucosa, I have to mention focally enhanced gastritis. I know we spoke about it earlier yesterday, but this is not something that I take lightly in older patients. In younger patients, which is patients aged in 30s and 40s, because I am asking the clinician to do a lower on him because to rule out Crohn's disease. But when I see active inflammation in the stomach alone, I wouldn't just call it straightforward NSAID. It has to be on a differential.
Got it.
Okay.
Thank you.
Sure.
Okay. So NSAIDs will inhibit cyclooxygenase, decrease prostaglandins, decrease mucus, acid neutralizing bicarbonate, and mucosal blood flow. Also deplete ATP, that's the pathophysiology. Inflammation, ulceration in any part of the GIT. Strictures or diaphragm disease in which there will be mucosal webs, and erosion, ulceration in any part of the GIT. Esophagus, acute esophagitis, ulceration and stricture. Stomach, reactive gastropathy and ulceration. And intestine, mostly active inflammation with some mild chronic architectural changes, ulceration or lymphocytic and collagenous colitis. PPI. So PPI used to treat esophagitis and peptic ulcer disease. So that's the pathophysiology. It will inhibit the parietal cell secretion, less stomach acid, gastrin secretion will increase, will cause parietal cell hypertrophy and neuroendocrine cell hyperplasia. So over here, you'll start seeing more fundic gland polyps in the PPI. Colchicine for gout basically inhibits the microtubule polymerization, interferes with mitosis, chemotaxis, and PMN degranulation. Most characteristic finding is multiple arrested mitotic phases, metaphase mitosis, particularly ring mitosis in colchicine. Also often apoptotic bodies and lots of reactive changes. So ring mitosis, colchicine. Cytotoxic chemotherapy, epithelial atypia. Epithelial atypia, sometimes mimicking dysplasia. Taxol, ring mitosis like colchicine. Okay. Mm, Severe neutropenia can cause neutropenic colitis, whereafter mucosal damage opportunistic bacteria invade causing necrosis and pneumatosis, often septic shock. So again, do you like, I think Dr. Aki also joined, but do you guys see call like cytotoxic chemotherapy right away in your reports for if you see these features?
So what I do is I suggest it. Okay. And if I have the history of the patient that he's been on these drugs, I'll definitely be more comfortable suggesting it. Otherwise, I'll be more descriptive. But yes, especially when I see those ring mitoses, it's kind of a happy day for me that I think I know that this patient is on this drug, and I confirm it and I do mention it.
It's raining. It's raining.
Let me mute. There's someone. Okay, good. Thank you. Dr. Aki is also with us. Dr. Ashwin Aki. Hi, Dr. Aki.
Hi, how are you guys? Thanks for including me.
Thank you. Can you introduce yourself for the group, please?
Sure. Yeah, my name is Ashwin Aki. I'm an associate professor of GI and liver pathology here at the University of Florida. I've been here 4.5 years now. I trained at Montefiore Medical Center for my fellowship and University of Chicago for my residency. I'm involved in medical school and resident teaching here at the university. And I'm also the fellowship director for GI.
Well, many of the residents will be happy to know that. Thank you very much for joining us. It will be very helpful to have your inputs in here. So what we are going to do is we are just going to read the notes and like the random questions that anyone has in the group, they are going to ask those questions. And you both, like, we also have Dr. Alsati in here. She's also a practicing GI pathologist since 5 years. And we are going to direct our questions to both of you guys. All right. All right then. So I'm gonna start, and feel free to say anything in between or explain, or if you have your experiences to share, please do that.
Sure.
All right. So antacids and sucralfate, gastric metastatic calcifications. All right. Due to calcium and phosphate imbalances, small calcifications under the mucosal surfaces. Okay. Iron. So again, iron pill, and iron appears brown and granular on the H&E and blue on the iron stain, usually associated with erosion and ulceration, sometimes reactive chemical gastropathy or chronic gastritis. So iron deposition pattern, deposition in the lamina propria, means there must have been a prior mucosal microhemorrhages. Coarse crystals at the surface, that more often is iron pill gastritis, and subtle uniform deposition in the deep glands, if that's more of the iron root. Okay. Resins we read yesterday, K-oxalate and fish scale pattern, sevelamer with the fish scale pattern, and the bile acid sequestrants. Doxycycline, so superficial mucosal necrosis or erosion, capillary damage with microthrombi and hyaline necrosis. Background reactive chemical gastritis and chronic gastritis. Angiotensin II receptor blockers. So these are sartan drugs, and olmesartan, losartan, used to treat hypertension. Induces severe diarrhea. Okay. Diurnal changes, often indistinguishable from celiac disease, will include, so angiotensin II, olmesartan and losartan will be similar to celiac, will be having villus blunting, increased intraepithelial lymphocytes. So do you have a set comment that says that increase intraepithelial lymphocytes and villus blunting comment, and what do you write in those comments?
It depends on the clinical scenario, and if we know that patient has been taking these drugs for a while, then I'd normally top line it as, depending on the extent of blunting. If I try to describe how bad the blunting is. If it's very severe, then I do say that it's severe villus blunting. If not, mild or focal villus blunting, and then increased or patchy prominent intraepithelial lymphocytes, depending on how extensive it is. And then give the differential. And in this case, if I know that the patient is on these medications, then I suggest this is likely related to the patient's known history of angiotensin receptor blockers.
And I would like to add something else. Also, I would also look at the patient's stomach, and an H pylori infection also can, like severe H pylori infection can cause, lots of intraepithelial lymphocytes within the duodenal mucosae. Not as much blunting though. So, if there's patient is H pylori, I will also mention that this might be H pylori related injury, as well as drugs and emerging celiac, and correlation with serology is recommended.
Got you. Okay. Thank you. And then you see this subepithelial collagen deposition can also be seen with the olmesartan and losartan. That's important. Okay. Mycophenolate mofetil. So as we saw before, more of apoptosis, that's the typical. So immunosuppressive drug used after solid organ transplantation, GI toxic, often limiting use. So this will resemble GVHD or Crohn's disease, and increased script apoptosis and patchy neutrophilic inflammation and degenerating damaged crypts, architectural damage, and granulomas. More EOs favor the drug effect, more apoptosis favors the GVHD. Okay. So bowel prep effect, this is a very nice picture. Basically, many act through increasing osmolarity of the stool, traps water in the lumen and moves. Mucin depletion, so focal active colitis or cryptitis, and increased apoptosis again, erosions. And then increased active cryptitis and erosions and apoptotic bodies. For the melanocyst coli, so then you have irritant laxatives, but actually indicator of epithelial cell turnover. So again, you have apoptosis, but these macrophages, phagocytized macrophages, which I love, lipofuscin accumulates and looks yellow and brown. Can be seen also with many drugs, including NSAIDs. Okay. Checkpoint inhibitors. And so far, anyone has any questions that we have read? Okay. I think Shweta has not joined today.
I just joined in.
Yes, you are our question bhandar.
Ah,
All right. So checkpoint inhibitors. Anti-PD-1, anti-PD-L1, anti-CTLA therapy activate immune tumor destruction, but can also cause autoimmune or immune-related adverse events, response to steroid. So over here, you will have in the checkpoint inhibitors, colon will have lymphocytic colitis, collagenous colitis, acute self-limited colitis, and apoptotic colitis. Stomach will have perigland inflammation, focal enhancing gastritis pattern, not diffuse. Duodenum will have villus blunting, increased intraepithelial lymphocytes, apoptosis, and Brunner gland inflammation. So that's your checkpoint inhibitor. Have you guys seen a case of this checkpoint inhibitor induced like any of these colitis, gastritis, or duodenitis?
I've had a couple of cases, both in the colon and in the duodenum. The colon one was somewhat non-specific, just like lymphocytic colitis with occasional apoptosis. So that was not too specific. The duodenal one, especially when we knew that the patient did not have celiac, and the interesting thing was even when they did endoscopy, they did notice scalloping. And then on our biopsy, we saw significant, or I saw significant villus blunting with increased intraepithelial lymphocytes. So It was pretty classic for checkpoint inhibitor therapy.
Very nice. That's good. Okay.
And this focal enhanced gastritis.
I have not
That's-
seen stomach, but yeah, others may have.
I just want to say that the focal enhanced gastritis is quite often seen, especially in the pediatric age group. And there, the clinical suspicion, like in the differential diagnosis, first one would be inflammatory bowel disease. But I mean, once that is ruled out, or if the patient does not have that history in the adult populations, it's always good to think of like the patient is on therapy.
Okay. Can I ask who was the one talking? I couldn't ascertain from.
This is Priya. I can't
Priya,
hide it.
Priya. Yeah.
Yeah, I was like, it looked like Priya. Okay, good. Okay. Are you the iPhone?
Yeah, I'll change my name.
Yeah.
Sorry.
Yeah, okay, that's fine. All right. So thank you. Idilasib, specific small molecule drug used to treat CLL, SLL, and follicular lymphoma. Causes severe diarrhea. Okay. Changes seen in colon and small bowel. Increased apoptosis. This is really fulminant. Lymphocytic colitis and focal active colitis or cryptitis. Okay, I'll have to look for these drugs. I mean, that would be so cool to diagnose that it is idilasib associated colitis. Have you seen any cases? It's not so
I
common.
haven't.
I
Yeah,
had
it's not
one.
so. You have one?
Yeah,
It's not so common, no?
yeah, not very common.
Okay. Yeah, yttrium labeled microspheres. I remember this one from yesterday. Appears uniform dark, appears uniform dark, opaque, perfect circles, and given interventional radiology as internal radiation therapy for hepatic malignancies. Often also see radiation injury. Most common to see upper GI due to shared circulation with the liver. Okay. Additional diuretics will decrease the circulatory volume, bowel ischemia at usual watershed areas. See classic ischemic findings. There will be crypt withering, lamina propria hyalinization. Okay. Ergotamine, wow. That's for migraines and will cause vasospasm, can cause ischemia, localized ischemia in the GIT. Small localized ischemic ulcers, not in watershed zones. Glutaraldehyde, used to disinfect colonoscopes, useless now. Contact irritant in colon and rectum. And hormonal therapy or oral contraceptives. Estrogen produces hypercoagulable state and causes thrombosis in the mesenteric veins and ischemic colitis. So, so they have the list of most common ordering medications, which I'm not going to go through. You can go through yourself if you're interested, you guys. All right, so that's this one. Let's do the next. So far, any questions, Shweta? Anyone else?
All good.
All good. Okay, good. GI infections. So our favorite Helicobacter. So slender curved rods. So sexy. Sorry. Very common, infects half of the world population, especially underdeveloped countries and person-to-person contact. Acute infection will cause chronic active gastritis with superficial lymphoplasmacytic infiltrate. More prevalent in the antrum, often erosions and germinal center formation can cause marked lymphoma. Heilmaniae, this is even better. Corkscrew appearance, milder inflammation, may be acquired from domestic animals and especially prevalent in children, less likely to cause lymphoma. Both stain with Giemsa, silver, and some immunohistochemical stains. Treat with triple therapy, that will be 2 antibiotics and PPI. Spirocitosis, this is such a nice picture. I wonder where he brings his pictures from, this Kurt's notes from Dr. Schaubach. I really wonder. I mean, he has mentioned some, I think he mentioned some like, the resources somewhere, but all the pictures are really nice. So
I had a question, Akanksha. In cases of treated H. pylori gastritis, if there's a recurrence, does the organism still retain its morphology?
I would think so.
I
Yeah,
don't
I
see
think
it.
I think it's fine. You will see sometimes the cocci looking, the one they just look like little circles and dots and partially treated. However, if you notice that the patient has been treated with H. pylori, and after 3 months or 6 months, he biopsied them again, and then the H. pylori is all over the place, it's as if the patient did not even get treated. So it might raise the possibility of resistance. And there is very few centers in the United States that test for H. pylori resistant microorganisms, antibiotic resistant H. pylori, sorry. So yeah, so it will retain the shape of it, but yeah, you might have like more of coccyx looking H. pylori.
Yeah, thank you. We recently had a case and I was like, this doesn't look like the classic. So probably it was partially treated or so.
The other thing that we've noticed is, in addition to changing the shape to becoming more coccyx, we've also noticed that the organisms go deeper and deeper into the crypts, and sometimes in treated patients, we've seen that you can only identify the organisms in the lymphoid aggregates within the mucosa. And so in those cases, we do mention, just so that the clinicians are aware that, we're not seeing it in the mucosa, but there are, organisms or staining within lymphoid aggregates, which is reminiscent of treated H. pylori. We do mention it for our clinicians.
Dr. Akil, I have a question for you. Did you ever encounter H. pylori staining plasma cells, and they're just like focal non-specific staining within the plasma cells? It's not really like an organism. It's not in the lumen. And you know that the patient had history of H. pylori. For me, I ignore this stain. I don't really call it positive, but for some reason I find these from time to time. Some of the plasma cells are positive for H. pylori immunostain. Did you get that anywhere?
No, I don't remember seeing them in a plasma cell.
Okay.
But we've had quite a few cases in the lymphoid aggregates in the stomach. You know how deep down in the mucosa,
Right.
some patients have these lymphoid aggregates, and we've seen coccyid forms hiding in there.
Right.
But
Yeah,
no,
I call these positive. I do call them. I kind of I can relate to what you're saying, and I just call them positive cases, but it's very difficult to find because they're very rare, very distant apart. So
yeah, and the overlying mucosa is completely negative, and you're only finding these in these lymphoid aggregates, and that's what makes it challenging. So yeah.
Could that be a precursor to lymphoma in the making?
It's too early, I guess, or too hard to say, I guess, but maybe, you never know.
Okay, thank you.
And then for the staining for H. pylori, like what is your protocol? I know the reimbursement for it is like my institute questions like staining and like ask us to like refrain from it because there are some issues with the reimbursement. It's like not reimbursed something. So what protocol kind of you use for staining? And if you have both biopsy of cardia, body and antrum, and like every part has lymphoplasmacytic infiltrate increase. So do you stain all or you just stain the antrum?
in my practice, I do antrum and ulcers. And I stain pretty much every case unless the patient is a self-pay. If the patient is a self-pay, I will order H. pylori after I look at the H&E. This is my protocol. And if I have one of the biopsy positive for H. pylori, I won't add any more H. pylori immunostain on the rest of them. Let's say if I have 6 biopsies, I'll only do it on one. which is the routine one. Unless I have that migration phenomena and I see that the interim is completely negative and the body is very, very exuberantly inflamed, I'll go ahead and order an H. pylori on the body. But yeah, that's the process that I take in my practice.
Yeah.
Okay, so you start with interim, and if it is negative, then only you go to like body then.
If needed.
If needed, yeah, sure. Okay.
So I just like Dr. Alzate was saying, I look at if there are multiple biopsies from different parts, I choose the one which has the acute inflammation, if any. If not, then whichever has the most severe, I go with. And depending on what the one or two foci show, then I proceed with doing more if needed. But yeah, in my training programs, the immunostains were ordered by default on all antrums, but here in my current practice, we order it as needed.
Yeah, ordering without any inflammation, like it will be, I don't think that will be much.
No.
Yeah. I mean, every practice is different, but I think in my training program, to save the pathologist's time, they were ordered by default. But yeah, here we only order it if there is suspicion.
But how is that saving time? That slide is going to be needing interpretation as well, right?
Well,
it will save a day.
The turnaround time is what I meant.
Yeah. That's what we used to do in our bone marrow. So I am a hematopathologist, and we used to see we used to train our, like the office people, and they would have the history, like they would get the history. And if the patient is having CLL, they will pre-order CD320 and PAX5. And if the patient has MDS, AML or something, they will pre-order CD34, CD117. And that saves a day, which is a very good, All right, very good discussions. Let's go ahead. So intestinal spirochitosis, fuzzy fringed layer of organisms at the surface, non-invasive. Variable species, most are Brachyspira. Usually no associated inflammatory infiltrate. Stains with silver stains, Wharton's diarrhea and Steiner. Clinical significance is somewhat unclear. Diarrhea, most common symptom, but unclear if usually causative or coincidental. Classical association with men who have HIV is also being questioned. Mycobacterium, so foamy macrophages in the lamina propria, often distending the villi, can have poorly formed granulomas, and that's the MAI infection. And then usually in the immunocompromised, and present with diarrhea, malabsorption, weight loss, and stain with AFB, fight, PAS, GMS. MTB, so there will be necrotizing caseating granulomas, coalescence of large granulomas, often with associated cup of lymphocytes. Organism stained with AFB and fight, but culture and or PCR may be required. Most common in ileocecum with sharply defined ulcers and strictures mimicking Crohn's, causing weight loss, fever, abdominal pain, and diarrhea. GI symptoms may precede pulmonary symptoms. So Whipple's again, we'll have those foamy macrophages. Infection by Tophiderma Whippley, present with weight loss, diarrhea, arthritis, lymphadenopathy, endocarditis, neuropsychiatric issues. Most common middle-aged white males with HLA-B27. Most often infect small bowel, but can see changes throughout the GIT and also brain, heart, and lymph nodes. Massive infiltration of lamina propria by foamy macrophages, variable acute inflammation. Organisms stained with PAS. Can also identify in the PCR, and negative for AFB fight and helping to differentiate MAI. Yersinia. Gram-negative Coccobacilliform enteric bacteria, infection caused by food contamination. Most commonly infects ileum, right colon, and appendix, and can cause ulcers, edema. Epithelioid, abundant epithelioid granulomas with lymphoid cuffs. So Yersinia, abundant epithelioid granulomas with lymphoid cuffs. Transmural lymphoid aggregates and giant cells common, usually non-necrotizing, closely mimics Crohn's disease. And stains are not helpful. Consider culture, serologies, or PCR. Common cause of granulomatous appendicitis. All right. Do you also see eosinophils, like increased eosinophils in Yersinia cases?
I haven't had the case.
Yeah, I haven't had a case either.
Okay.
It's probably very rare.
Yeah, I mean, that picture I can remember, but it's definitely very rare. Acute infectious colitis. So acute self-limited colitis, most commonly associated with bacterial enterocolitis. Usually acute onset of diarrhea and abdominal pain, often self-limited and resolves within several weeks, often discriminated from one another by microbiology testing, classically culture, but now PCR NATs. Classically, active colitis, cryptitis, cryptaxis, epithelial damage without the features of chronicity, preserved architecture, no metaplasia or basal lymphoplasmacytosis.
These chairs are so uncomfortable. I'm getting a backache. These chairs
Say
are,
again,
I got even the.
I'm just muting. I think that's a background noise. Okay, so we are reading the acute self-limited colitis. Please unmute yourself when you're speaking. So classically active colitis without features of chronicity. And most common bacteria, they are Campylobacter, Salmonella, E. coli. Salmonella can cause typhoid fever with hyperplastic tears, patches, ulcers, and necrosis. Less PMN. Okay, and EHEC, sugar-like toxin causing epithelial endothelial injury. C. Fibrin thrombi, ischemic changes, can cause hemolytic uremic syndrome due to endothelial injury and platelet activation, causing thrombocytopenia, hemolytic anemia, and kidney injury. Clostridium difficile, usually after recent antibiotic use. Watery diarrhea with pseudomembranes, and Shigella yersinia. Some viruses, including norovirus and parasites. Sarcina, wow. In the stomach. Spherical 2 to 3 micrometer in diameter tetrads, or packets of 8 or more, most commonly found in the stomach. Unclear if pathogenic, incidental finding. Often seen in cases of delayed gastric emptying or gastric outlet obstruction. The presence can prompt further investigation as to cause of dysfunction, such as occult malignancy. Have you ever seen a sarcina in stomach?
I have seen in my residency twice.
Oh wow, nice.
Yeah, but it's like clinician doesn't care much for it. It's like
Yeah, it looks
we
like
get
that.
excited, they don't.
Yeah, I've seen it once as well.
Say again.
I've had 2 or 3 cases, but I've seen it more commonly in diabetic patients where they have, motility problems with the stomach. So it's something that you can pick up in these cases and mention it to the clinician too. But yeah.
Okay, actinomyces, dust bunnies, frequently seen as incidental bacteria on the biopsies and part of mixed flora, colonizing lesions, especially in the oral cavity, associated with poor hygiene. Uncommon cause of appendicitis, positive on gram stain and GMS, negative on DFP. Normal flora. So most normal bacteria in the oral cavity intestines are gram negative and lows. In GI biopsies, often see in esophagus, intestines, and bacteroides species are most common. Other common includes Prevotella and Villanella. Other organisms include gram-positive organisms such as Streptococcus. Usually these are commensals and do not cause disease. Can cause periodontal disease. Elsewhere, most diseases due to spread to the other regions. So endocarditis, sepsis, septic arthritis, and pneumonia. Often polymicrobial clusters or infections, highlighted with gram or silver stains. Histological findings are non-specific and further microbiology should be done. Culture, Margita of NAT are necessary for Viruses, CMV. So most common in immunocompromised hosts, often causes ulceration, symptoms vary by site, esophagus, dysphagia or dinophagia, stomach, intestines, diarrhea, bloody or watery, pain, ulceration, mixed inflammatory infiltrate with neutrophils, if severely compromised, less inflammation, viral inclusions in the mesenchymal cells, most of commonly endothelium and other stromal cells, nuclear owl's eye, cowrie A, pink, nucleolus like, and then cytoplasmic granule and pink to purple, off-like. Be sure to evaluate for in refractory IBD or GVHD cases. You can also look for.
I have a question on this one. Now, I had a case where there was an esophageal ulcer and I did like CMV stain and only one like cell was kind of atypical and staining for CMV. How confident are you when you just see like one kind of that cell in a biopsy? And morphologically, it's not that convincing, but it's like kind of a little big cell. And so how do you deal with those?
Try to do a recut and take recuts and look for the morphologic features. And you can also repeat the stain. And if nothing stains positive in the recuts also, you can just say that rare positive cell suspicious for or something like that.
Well, suspicious won't help because like it's either like clinician has to treat
clinical
it or
correlation
not.
Is like the clinical correlation is recommended, something like that. Or if
Was the patient immunocompromised in your case?
No.
Okay, so their clinician suspicion is usually low in those cases, I would think.
Okay, so you call them the non-specific if you just see kind of one and then not immune compromised.
Yeah, rare positive. Okay. Yeah.
Okay.
They won't usually act on it. Okay.
It's like it's my send out stain, so I cannot do like to and fro like do much, and like biopsies are usually small. You fear to like do recuts on them because you lose the tissue, and like if it's a single cell which is abnormal, like on recuts you're gonna lose it. But if it was like if there was a cell which I thought like could be and not 100% sure, and then it stained, but that was the only one cell, and then I was stuck like where to go.
Yeah.
And they tend to be patchy also, like even in involvement. So that's a very tricky scenario.
Yeah, I'll definitely, from my end, I would not ignore it. I do have to mention it. I will show it around in my practice, ask if other doctors consider this a positive versus an artifact. So this is also something to keep in mind. If probably the most of them agree that this is a true stain, your problem is the rarity of it. It's like only one, and so my diagnostic line would be whatever chronic or active or whatever inflammation, and then as a second diagnostic line, I will call rare rare positive CMV immunostain seen. See comment in the comment section. This is non-specific. However, this could be a true infection in the appropriate clinical setting. Correlation with clinical is advised, something like that.
Okay, good. Yeah, thank you. Yeah, that helps. Yeah, thank you.
Sure.
All right.
I have a question. Is it always the same that CMV affects the endothelial cells? Is it always it happens like that?
I didn't get the question.
So she's asking whether CMV is always present in just the endothelial cells and nowhere else.
No, it could also be in the stromal cells in the lamina propria. Yeah, but yes, you can. For the most part, it's the epithelium. Is that your question?
Yeah. Okay. Thank you.
Okay. Let's go further. HSV most commonly causes ulceration with variable inflammation and predominantly acute, can get vesicles in the anorectum, viral inclusions at the edges of the ulcers in epithelial cells, 3Ms, Second most common cause of infectious esophagitis. Dysphagia, self-limiting in healthy patients, may cause esophageal perforation, disseminate in the immunocompromised patients. Findings will be the same in HSV 1 and 2. Adenovirus, childhood diarrhea can cause intussusception. Immunocompromised hosts will lead to diarrhea, potentially leading to disseminated disease and will be hard to control. Smudgy inclusions. So nice smudgy inclusions be typical. Tubular GIT, inclusions in the surface epithelium, often in the goblet cells. Can be round or crescent shape, most often in colon with increased apoptosis and epithelial sloughing. Include in the liver, inclusions will be in the hepatocytes and often edges of the coagulated necrosis. Okay. Candida. Most common infection of the esophagus, most common in the immunocompromised patients with dysphagia or rhinophagia. Endoscopy, there will be white plaques with underlying ulceration. Neutrophilic inflammation with ulceration, but less if immunocompromised. Parakeratosis will be there, highlighted by PST and GMS stains, and C-mix of budding yeast and pseudohyphae. Histoplasmosis, endemic in Ohio, Missouri, Mississippi River valleys, can cause localized or disseminated disease, more common in immunocompromised. Lung, most common site. GI is more common too. Most common GI is ileum, may cause ulcers or mass, often lymphohistiocytic infiltrate without well-formed granulomas. Intracellular 2 to 5 micrometer fungi, positive with GMS and PS. Cryptococcus, avian dropping pigeons, immunocompromised. Most common site, lung and meninges, and can be disseminated, which can lead to GI. Variable inflammatory response and can have granulomas or suppurative necrosis. So they are very pleomorphic, 4 to 7 micrometer, lots of different sizes, and round to oval, narrow based buds, and unstained refringent capsule give halo or soap bubble appearance. I'm gonna mute, there's some background coming. Stains with GMS, capsule stains with mucicarmine. Coccidoides, valley fever, soil in southwestern United States, immunocompromised again, can have localized or disseminated, and then endospore containing the spirules, often associated with granulomatous and chronic inflammation. Strongyloides, pretty. Nematode with worldwide distribution, very common in tropics and southwestern US, southeastern US. Often gets through the skin when barefoot on contaminated soil. Skin goes to lung, GIT, feces, next post, auto-infect. Worst in immunocompromised patients, can be symptomatic and harbor more than 30 years. When symptomatic, diarrhea, pain, and bleeding. Inflammation with neutrophils and eosinophils. Often may resemble IBD. And adult worm larvae and eggs are all found in the crypts. Enterobius pinworm. Spread by fecal oral route. Humans are the only host, most common in children. How frequently do you see these enterobius and strongyloides in your cases?
Oh, pretty
Enterobius,
common.
Sorry.
Oh, sorry. You go ahead.
Yeah, I have seen enterobius in the appendix, but not others. Like in the lung, I have seen like histo and others, but not in the GI.
Yeah, but I have seen cases of strongyloides, and I was wondering like how common it is. And like enterobius, I think I saw some unknown cases of that, but like I in my practice, I haven't come across, like in my little practice, 1 year practice, I haven't come across that. You were saying something?
Yeah, I do get those worms from time to time. And the best part is when you look for the eggs and try to figure out from the eggs with the lateral spikes, is it trichuria, you know? And I've got some schistosomas. Actually, I mean, at least twice a year I get schistosoma. When I get calcifications in my colon, schisto always comes to my mind because it calcifies and it dies and it looks like a non-specific calcification. I always order stains, and not stains, sorry, levels to make sure if others popped up to look for it. So yeah, you should always keep that in mind when you're looking through your GI. It's filled with bugs.
Mm-hmm. You were saying something, Dr. Aki, as well?
Oh yeah, I mean, I've had 1 or 2 cases of enterobius in the appendix, and then a couple of strongylitis and then schistosoma, but not too frequently, you know, like once or twice a year.
I had a echinococcus once and a liver cyst.
Oh, cool.
That was really cool.
Yeah.
All right. So pinworm we read in the appendix, and lateral spikes, characteristic lateral spikes, minimal inflammation. Schistosomiasis, any species of schisto can be found in the gut, and then highest prevalence in sub-Saharan Africa and Middle East, contaminated water. Through the skin, snails are the intermediate host, and asymptomatic patients will be asymptomatic and present with GI bleeding. Ova found in the wall of GI or GUT often calcify. So these are all the ovas. Calcifies with time, variable acute or chronic granulomatous inflammation, often prominent eosinophils. Worms often have no reaction to them, found in veins of bladder or bowel, or in the liver, and lay eggs into urine or stool. 3 main species, Mansoni, Japonicum, and Hematobium. Mansoni will have lateral spine, Japonicum will have later knob, and Hematobium is the terminal spine. Hematobium will be more in the bladder. Liver flukes. So occlude the bile duct and dilated ducts with wall thickening. Suggestive signs of biliary obstruction will be there with jaundice, fever, right upper quadrant pain. Can cause cholangiocarcinoma, long-term due to chronic inflammation. Clonorchis sinensis, Opisthochus, and Fasciola species. Endemic primarily to Asia and acquired by eating raw or undercooked fish or crawfish. Worms visible to the naked eye. Echinococcus. It's so cool. Cystode tapeworm with wide geographic distribution. Definite host dogs, other carnivore. I really wonder where he gets all his images. This is so awesome. Eggs hatch, larvae travel to the liver and form cysts. Cysts grow very slowly, often asymptomatic, but can get symptoms from mass effects. Treated with surgical resection, ruptured cysts are very antigenic, can cause anaphylaxis. Innermost layer contains protoscolices, developing head of the adult tapeworm, and which contain 2 circles of the hootlets and a sucker. And then this is surrounded by a layer of hyalinized white laminated cellular material. Entamoeba, subtropical and tropical regions, fecal-oral route, contaminated food, will cause diarrhea, liver abscesses, flask-shaped ulcers. That's how many, like, how common is it? I have like this theoretically always have flask-shaped ulcers and amoeba, but how common is it?
I had one case in my practice, only one, and I was showing it all over the place for like a month.
Oh, obviously.
I'm serious. I texted it to everybody in my life. Yeah. So yeah, I've only seen it once.
So I've also seen just one case. It doesn't necessarily have to be flask shaped. Of course, for board's purposes, that's the shape. But you know, if you notice these organisms, then yeah, you have to do further investigation or show it to a microbiologist who can confirm that this is indeed entamoeba. But yeah, it's rare, but can happen, and doesn't necessarily in real life doesn't have to be flask shape. Can be any shape.
Mhm. So then he has shown this picture of round red eccentric nucleus, distinct cell membranes, foamy cytoplasm, and ingested RBCs. Okay. Giardia. We know this is our favorite. Most common protozoa infection in the US, and usually acquired from contaminated water, can be STD. Most common in kids and travel, immunocompromised, causes diarrhea, often watery and foul smelling, and can be chronic, especially in immunocompromised. Usually see trophozoites with no associated inflammation. Sometimes mild villus blunting and chronic inflammation can be there. Trophozoites are pear-shaped with two oval nuclei, looking falling leaves in the bowel lumen. Cryptosporidia, often the obligate intracellular word-bite parasite, can be from contaminated water or person to person. Diarrhea, self-limited in normal host, but also chronic or relapsing. And with weight loss and cramping in the immunocompromised, no good therapy. Parasites appear as basophilic blue heads on the lumina apical surface. Can see villus blunting, variable inflammatory infiltrate, and enveloped by microvilli, less microvilli for absorption and then causing diarrhea. Cystoisospora. Some formerly just isospora. Obligate intracellular worldwide parasite. Infected by contaminated food water, causes diarrhea chronic, debilitating if immunocompromised, villus blunting with mixed inflammation and prominent eosinophils, variable forms, all intraepithelial. Crescent or banana shaped, others with round with prominent nucleoli. Oh my God. Have you guys seen any case of cystoisospora?
I haven't, but I'm so worried that I missed it.
Yeah, I know. Like it is very easy to miss. It looks like
Yeah,
it's
very difficult.
One of my colleagues had a case in gallbladder, not in the luminal GI tract, but yeah, I have not seen one.
And there is no stain for them too. I mean, it's very hard to just say that it is cystoisospora just based on what we see here. No?
Oh gosh.
Yeah.
Cyclospora, another one. A. Okay, this one is fine. I can see this one. Protozoan with worldwide distribution causing diarrhea. Infection often occurs through contaminated food or water. Variable villus blunting and inflammation. Round 2 to 3 micrometer forms and presenting merozoites in parasitophorous vacuoles. Microsporidia, this one's nice. Fungus causing intestinal infection, particularly in AIDS patients. Diarrhea, small spores, and larger plasmodia, located within supranuclear cytoplasm of the epithelial cells. Okay, so we are done with this one. And let's do our probably last one for today. No, just two, then this is not the last one. Hirschsprungs. Okay, this is more. All right, so this looks like a nice representation. Here is the normal bowel. Here is the transition zone. So normal bowel, the ganglion cells will be present. Transition zone present but fewer. And then Hirschsprung segment, it would be absent. And then the hypoganglionated segment, absent to few. And then neural hypertrophy will be present in the transition zone. So it will start from the transition zone itself. And then nerve twigs will be absent in case of the Hirschsprung segment. And mucosa, colorectal, okay. Inadequate to confirm absence of ganglion cells as physiologically hypoganglionated. Okay. We don't get Hirschsprung's biopsies, thankfully, in our practice. I mean, I don't know, thankfully or non-thankfully, because I don't get any practice for that. But,
It's only very, I mean, it's a very common thing in the pediatric age group.
yeah,
So,
I
I
used
mean,
to
it's
get
often,
it in.
yeah.
I used to get it in the residency very often. My pediatric pathologist used to take us for the frozen sections all the time.
Frozen, yep.
Yeah.
Very
but over
common
here,
for frozen.
yeah. All right. So congenital absence of ganglion cells in both nerve plexuses, submucosal and myelin. I remember her, like she was very aggressive lady, and she would, I should not say that, she might listen to this, but she was like, okay, you have to remember it is in the submucosal, it is in the myelin. Wow, she was awesome person. Leads to poor peristalsis, obstruction, proximal dilatation with narrowed spastic distal ganglion segment, failure to pass meconium, abdominal distension, constipation, can get enterocolitis. Always impacts distal most part of GID. Okay. Farther, for neural cells to travel to make ganglion cells. Okay. Suction biopsy protocol. So basically, preoperative rectal suction biopsies are done to establish the diagnosis. Biopsy should be more than 3 millimeter in diameter, should be at least 1/3 of the thickness of the, 1/3 thickness should be at least submucosa. Should be more than 2 centimeter above the dentate line. I'm gonna mute someone else. Yeah. Should be more than 2 centimeter above the dentate line to avoid physiological area of pure ganglion cells. Multiple serial sections will be examined. If no ganglion cells, order additional cell levels. Yeah, I know this is a pain in the, you know. And Carleton and IHC. I did not like those cases in the residency. Ancillary studies, Carleton shows granular staining of small intrinsic nerve twigs in the mucosa and muscularis mucosa anomaly, which are absent in Hirschsprungs. Also highlight ganglion cells in nerve bodies. Okay. So
I
Hirschsprung will
don't
have no
practice
staining.
it right now. I have seen it in my residency. Can somebody who currently practices it can tell like what on frozen section you do? Like, do you do colretinine too during like frozen section? Like,
No.
I mean, order it and kind of any emergent stains that you order on it. And what do you report it as? Like ganglions present or absent, nerves present or absent, and nerve thickness. Like, how far do you go when you report the frozen?
We don't do frozens on these, but we look at them for permanence. And we order 60 levels and with 3 levels on each slide. That's the protocol that we established, and then calretinine too. But no, we don't do frozens.
We used to do frozen on the residency, and they basically wanted to know how much to resect. And when you start seeing the ganglion cells, that's what their target was. And like my pediatric pathologist, she would go all the time. Like they would always frozen. They would. I mean, that's something that our practice had. I think our institution had. But they were always frozen, and it was always that how much segment is involved and can we stop resecting, something like that.
Okay, and do you mention if nerves are present and if ganglions are absent and then nerves present, or you don't mention about the nerves in the frozen?
She used to see for the nerves. I mean,
Okay.
this pediatric pathologist, she used to see for the nerves, and hypertrophy of the nerves was another sign apart from the ganglion cells that she used to see. And like,
yeah, it supports basically.
Yeah, it supports.
Yeah, it basically favors the absence of ganglion cells.
Okay.
And chronicity and everything.
All right, so we are done with the inflammatory. 502. Dr. Aki and Dr. Alsati, tell me if you guys have time, we can go further, or you want to stop here.
I need to leave, but I'm happy for you guys to continue.
Okay. What about you, Dr. Alsati? You have to leave as well?
I can stay for another 15 minutes if
Okay. Perfect. So let's do the esophageal tumors in the next 15 minutes. 5 pages, so that's easy. And before you leave, Dr. Aki, are you still here? Yes. Before you leave, tell me, so Dr. Alsati is going to be there in the weekend. So we are planning to have a weekend session as well. And Dr. Alsati is going to be there from 10 to 12 Eastern time. Will you be able to get any time? I mean, I know that I'm asking for too much, but will you get any time after 12 for us to continue? Or
This is
before 10?
on Saturday, you mean?
Yes.
Okay.
Before 10 or after 12?
I can let you know in a day or two. Does that work?
Sure.
It's
Definitely.
hard for me.
I mean,
Okay.
it's not a obligation or anything of any kind. Please do join whenever you are available, and we will try to be consistent at 4 to 5 or 4 to 5:15, 5:30ish on the weekdays. And
What are you
we'll
planning
try.
on the weekend? Sorry.
Say again.
What are you planning for this weekend?
For this weekend, we are going to probably do the path presenter slides, and we are going to look them together, discuss them.
Okay.
And if at all any of the Kurt's notes are remaining, we'll continue reading that as well.
Okay. I'll let you know.
Yeah. Will you be able to come tomorrow if we keep a session?
Yeah, I should be. Yeah.
Okay, perfect. All right. So I'll keep in touch with you, and thank you for joining. Okay.
Yeah, no problem. Thank you.
All right. So esophageal tumors, benign incidental findings, pancreatic heterotopia. So normal incidental findings will be pancreatic heterotopia or metaplasia, multi-layered epithelium. Epithelium at transition between squamous and glandular mucosa with some features of both. Looks like squamous, metaplasia of the cervix. Inlet patch, we saw that stomach epithelium in the upper esophagus. Glandular lesions, complete intestinal metaplasia. Okay. Exact duplicate of intestinal mucosa with absorptive cells between the goblet cells, usually in the stomach. Incomplete intestinal metaplasia is goblet cells with intervening foveolar cells, more common in the GEG. Higher risk of dysplasia in case of incomplete. Do you mention that complete, incomplete? I mean, in our practices, I haven't seen.
I'm glad you asked. So in my practice, I receive biopsies from around 12 different centers. One of them asks for distinction between complete or incomplete, and it's the biggest one. So I basically got into the habit of always describing the difference. And at first I thought it was like something very difficult and very impossible for me to distinguish. And lots of the cases I had mixed cases. So I contacted Dr. Oh my God, what's her name? The Hopkins, Dr.
Montgomery?
Florida. Yeah, Montgomery. Yeah. I contacted Montgomery and I'm like, okay, so what do we do right now? I have a case with mixed. I have both incomplete and complete. And then she said the incomplete rules. So if you have one gland only incomplete, you call it incomplete type. Okay. Even if it's loaded with complete type IM. So it's like almost like Gleason scoring. If you have a 4 and a 5 and a 4 and a 3 and the 4 always goes before the 3. So yeah, we do. I do use it in my practice very often. And it makes a difference for the clinician. Those who I speak to them, they will bring the patient earlier. They will take more biopsies when they do follow-ups on these patients. They will follow them more stringently when it comes to incomplete.
So the difference between complete and incomplete is just that in the incomplete, you'll have intervening like foveolar cells. And
okay, so here's the thing. So if you have a goblet cell in a gastric foveolar mucosa, okay, you call this an incomplete because the foveolar epithelium and the mucin caps are on top of your goblet cell. Okay? If your goblet cell is in a place where the cytoplasm around it is pink with a top brush border and you lost the foveolar mucin cap, you have a complete. The word complete means the goblet cell went into that cell and it actually made it look like completely identical to intestinal mucosa. Okay, so I went there, I took on the cytoplasm, I switched the brush border into an intestinal type. So now I have achieved my my mission and I have a complete type and IM. Versus I went there, the foveolar epithelium is very resilient, does not want to give me space to move on to a brush border. So I am incomplete. And the incomplete becomes very aggressive. There's like almost fighting between the foveolar epithelium and that goblet cell. And that's why we know they are, this is more a dysplastic process because that goblet cell, like, that's how I think about it when I'm looking at mastitis. Why is it more aggressive? It's because it's incomplete. It's never felt that it's home. So they will become dysplastic. Okay?
That makes sense.
I don't know if it makes sense.
Yeah, it does. All right. Barrett's esophagus, I'm reading on the right-hand side. British and Japanese, they will say columnar epithelium regardless of the goblet cells, extending more than 1 centimeter above the gastric folds. And according to the AGA 2011, columnar epithelium with goblet cells in the esophagus, no length requirement. According to 2016 SAGE, columnar epithelium with goblet cells extending more than 1 centimeter above the gastric folds. What do you do? Like, which one do you follow? I would call it any goblet cell as intestinal metaplasia, and then comment that would be.
That's right. That's right.
Yeah. Okay. Risk factors: GERD, obesity, milk, male gender, smoking, H pylori, pathogenesis, acid bile reflex. Okay. Mutations, DP53, dysplasia. Okay. All right. Negative for dysplasia should be most common diagnosis by far. Surface maturation, 4 lines, shows preserved cell polarity. Apical mucin cap, first line. Base mucin cap, cytoplasm between mucin and the nucleus, row of nuclei. So that is basically maintaining the polarity. Wild type P53 staining, so they are also doing P53 again. And then management, follow-up in 3 to 5 years. All right. I really want to do a P53 on one of my biopsies today.
Indefinite. This Nehal. So
yeah,
we used to do Ki67 and P53 to, if at all we suspect dysplasia in Barrett. And for those, if Ki67, if it is like, basically the surface maturation is the key. If you do not see surface maturation at all and you see Ki67 in the upper layer or surface, then that is more worrisome. And again, right. P53, if it is like, wild type, as you might have seen in yesterday's, I think Hansen sent the video. In that one, the wild type and the not wild type, I mean mutated, you see like a very dark staining throughout the dysplastic portion. So combination of both Ki67 and P53, if you see both, then it is more indicative of dysplasia. And again, if there is a infection, like, if you see neutrophils, I usually like give a comment saying there is.
No, yours is better. I don't know why, but did you modify some stuff?
Can you hear me?
Yeah, she muted herself. Please.
Okay, yeah. So where was I? If you have both, like, Ki67 positivity and P53 both, then I would call it dysplasia. But then if there is a infection or, any inflammation around it, then I discount that, even though, like, you know, if the KI is positive as well. I think P53 is more, I can say, useful than KI, but I use both in combination and they support each other.
Got it. Okay. Nice. Good to know. All right. Indefinitive for dysplasia, used in cases when unclear if there is true dysplasia, often obscuring inflammation or partial maturation. Could consider getting P53 IHC. Management, treat for reflux, hoping things calm down, and repeat biopsy in 3 to 6 months. Low-grade dysplasia. So this will be more of adenoma-like, truly dysplastic appearing, in typical intestinal type, and pencillate hyperchromatic nuclei, extends to the surface epithelium. Often abrupt transition, that's important, from reactive to neoplastic, loss of 4 lines, but retained basal nuclei. Hyperchromatic nuclei, mucosal ablation is management. High-grade dysplasia, nuclear hyperchromasia and pleomorphism, loss of cell and nuclear polarity, no surface maturation, round, irregular nuclei, rounding, complex architecture. Management, mucosal ablation if flat, and EMR if mucosal irregularity to rule out carcinoma. P53 IHC considered indicative of dysplasia/neoplasia if overexpressed, every nucleus is strong, or null, every tumor cell is negative.
Does P53 help when there is acute inflammation, or it doesn't? Like, I mean, KI won't probably when there is inflammation, but does P53 still stands when there is an inflammation and you are like in between dysplasia versus reactive? Then would P53 be helpful?
Well, I don't have any. Snehal was talking.
Yeah.
Snehal.
P53, like there are a couple cases I have seen in, like, if P53, if it is nice and positive, it helps. But like if it is not, it is kind of so. Some areas it is showing wild type, some areas it's like, you know, overexpressed. Then I just call it like, you know, there is inflammation there. It's most probably reactive, and you know, a repeat after some time, you know, dysplasia, indefinite for dysplasia, and dysplasia cannot be like, you know, ruled out with confidence, something like that along those lines. And then again, as yesterday somebody said, you know, you get feel of the slide, like, you know, you just feel it. Oh, it's reactive, or it is going to dysplasia.
It's the thing is like you get a feel it's dysplastic, and your colleague has a feel it is like reactive. Then you are stuck.
Yeah, that's true. That happens all the time actually, especially these dysplasia cases.
Yeah, but that's pretty much the definition of indefinite. If you and your colleague don't agree, you also put that in words in a way that, you know, we're concerned, come back in 3 months, let's treat the inflammation, make it subside. I don't use indefinite for dysplasia very often. However, when I use it, I always reinforce that I want to see the biopsy again. You know what I mean? Like, I want the doctor to come back and biopsy this patient again after he treats him for inflammation. So, and sometimes I actually pick up the phone and call the clinician. I'm like, okay, you know what? Here's the deal with this case. Some of us think it's reactive. Some of us are very worried about dysplasia. And I'll feel much better if I have another biopsy in 6 months. You know, and just open communication. The problem with us is it's not with us. The problem with these cases is if they went from a place to another for consults or for second opinions, you don't want to be somebody who pulled the trigger where you shouldn't, and you don't want to be somebody who is falling behind when you should have done something. So being unsure and verbalizing that you are unsure will put you on the safe side and will actually put the patient in the right place, you know, because when you bring him up in 3 months, it's not like you're pushing him out for 3 years. Okay. I don't know. This is the thing that I use. I call a lot of my cases, not a lot, like few of my cases have went to Stanford and to UCSF, and they come back as yeah, we think this is indefinite, although we favor reactive. Yes, we think this is best classified as indefinite. We can't wait to see the follow-up biopsy, which is fine. Again, I don't use indefinite very often, but when I use it, I really make use of it.
Mhm. That's a very good perspective.
So the threshold is like with the inflammation, your threshold is like little higher then, right? Like if you see inflammation in the background and kind of dysplasia, then your threshold would be higher, or like it will remain the same and you will just be wordy for it, like you are suspicious.
Okay, if my threshold is right inside the cytoplasm, I'm sorry, if my active inflammation is right inside the cytoplasm, like intra-inflammatory, not only in the lamina propria. However, I have very dark, large nuclei, crib reforming. I do not care about the inflammation. Okay, if it is so round, if it's so bad, I don't care about the inflammation. But if it is a pencil shape, it's more of a low-grade dysplasia look. So it does make a difference when I'm looking at a low grade versus a high grade. It does. I don't know if it makes sense. It's every case is different than the other. I mean, you now opened a very challenging topic in the GI pathology that it's just something that I can go over and over, and a lot of us can agree and a lot of us can disagree about it. But what we should do is right for the patient.
I have one more question. I had a case, gastric mucosa was looking okay, and the squamous, like at GE junction, the squamous had some acute inflammation and dysplasia. So, and I didn't see metaplasia. So on those ones, where do you stand? Like, and like, what do you do with those?
Oh my God. Low-grade dysplasia, I never call it on esophageal GE junction biopsy. I have never called it, okay? So you have to be very careful. I mean, it's not that it doesn't happen, but you really have to have a very good dysplastic mucosa to call this low-grade dysplasia, okay? A slight inflammation is enough to back off, okay? And you don't have IM. So we're talking about squamous cells, like a precursor of a squamous cell carcinoma. If you think the mucosa of the esophageal mucosa is atypical, ask him to rebiopsy, ask him to come again, because most likely it is probably not a dysplastic process given the inflammation and sorry, can you hear me?
Yeah.
Yeah, I'm sorry, I got a phone call. I had to turn it off. Yeah, so most likely it is just a reflux change with exuberant inflammation that can be like lots of spongiosis, papillomatosis, and basal cell hyperplasia. But yeah, I don't know. I want to see others what they think. I've never called a low-grade dysplasia at the GE junction.
I usually send out these ones, and I have seen like the pathologists to whom I refer, they are different. Like if it goes to one of them, I know like what he'll answer, and if it goes to the other one, he will be different, and that what confuses me, and I cannot like make up on my mind like what exactly is the criteria what they follow.
Yeah, no, of course it makes a difference if the clinician is seeing a plaque or a patch or a nodule. You know, if the clinician, like endoscopically, is seeing something like a lesion. But if it is just a random GE junction biopsy, I would be very cautious.
Okay, got it. Good.
Okay.
Thank you.
Mm-hmm.
All right. Then coming to other types of glandular dysplasia other than intestinal. So there is foveolar type.
Very
difficult.
few.
Yeah. Very few, if any, goblet cells may arise independently. Prominent cytoplasmic mucin, hyperchromatic, slightly enlarged nuclei, possible pseudostratification. Basal crypt dysplasia. Dysplasia is the base of the crypt that matures at the surface. Small cell pattern, proliferation of numerous tiny monotonous glands with loss of polarity in nuclear hyperchromasia. Okay, adenocarcinoma. Invasion across the basement membrane, lamina propria overrun by the glands, may see single infiltrating cells or expansively growing glands without intervening lamina propria. Features associated with early invasion. So those features could be luminal necrosis, prominent nucleoli, glands growing parallel to the surface. Features associated with deep invasion, angulated glands, prominent desmoplasia at least into the submucosa, vegetoid spread of the malignant cells in the squamous epithelium. Nearly all occur in G junction due to Barrett's esophagus, often present with dysphagia. Classification shows mixed gastric or intestinal lineage, patterns of growth, tubular, most common, all right, papillary, mucinous signet ring, post prognosis signet ring, often mixture of patterns. Staging challenges, often in Barrett's esophagus, the muscularis mucosa can be duplicated and or distorted, which can make determining the depth of invasion challenging, particularly on the EMR. HER2, if amplified, approved for treatment of trastuzumab with trastuzumab. First, start with IHC. If focal 2+, then do fish. Management, if seems low stage clinically, that is just intramucosal, EMR and ablation. If advanced stage, that is going into submucosa or more, esophagectomy. If not too advanced, possibly chemo and radiation. After chemo radiation. Maybe hard to distinguish adenocarcinoma from squamous cell carcinoma requiring stains. And undifferentiated carcinoma should be considered if the IHC pattern is equivocal or if there is no definitive morphologic features. So adenocarcinoma and squamous cell carcinoma, CK7 positive, CK7 usually negative, P63, 56, 40, and those, and then PS mucin will be positive here and negative there. So tissue sample for patient diagnosed with GEA. So IHC, they're saying that 0 and 1+ for HER2 is no testing required, 2+ perform-ish, and 3+ no further ish is required. For the criteria, they are different than the breast, of course. So surgical specimen, no reactivity or membranous reactivity in less than 10% of the tumor cells is 0. Biopsy specimen, no reactivity in any tumor cells. Surgical specimen over here, 1+ is faint or barely perceptible membranous reactivity more than 10% cells. And then biopsy specimen, tumor cell cluster with faint or barely membranous reactivity irrespective of tumor cell stain. Okay. Cluster is important. Surgical specimens, so 2+ is weak to moderate, complete basolateral or lateral membranous reactivity, more than 10% of the tumor cells, and so complete over here, and moderate and complete basolateral lateral. And then biopsy specimen, tumor cell cluster with weak to moderate, complete basolateral or lateral membranous activity, irrespective of percentage of tumor cell stain. 3+, of course, strong, so more than 10% strong, complete basolateral lateral membranous, and then tumor cell cluster again with strong, complete basolateral or lateral membranous, with irrespective of percentage of the tumor cells. Okay. So that's the same thing. Okay, squamous papilloma. Papillary proliferation of squamous epithelium with fibrovascular core or lamina propria, benign, may contain coilocytes, but more dysplasia is rare, usually exophytic, but can be flat or endophytic. Results from mucosal irritation, stimulating a hyperregenerative response. Common irritations include HPV, GERD, trauma, etc. Squamous dysplasia. There would be cytologic atypia, nuclear enlargement, pleomorphism, hyperchromasia, loss of polarity, nuclear overlap. Architectural atypia, abnormal maturation, and low-grade dysplasia involving lower half, and mild atypia, high-grade more than half, severe atypia. Squamous cell carcinoma, intercellular bridges, keratinization, tobacco, alcohol, Asia, can be subtypes verrucous, spindle cell, basaloid. Verrucous, often in the setting of chronic irritation, exceedingly well differentiated with minimal atypia, papillary surface, broad pushing invasion with associated inflammation. Spindle cell, polypoid growth with high-grade spindle cell component, and basaloid, solid or nested with basaloid cells, no HPV association, unlike basaloid SCC in the old ranks. HPV is thought not to contribute significantly. Okay, so that is all for today. And that ends our session. Thank you very much, Dr. Alsati, and Dr. Aki is not here, but thanks to him as well. Thanks everyone for joining, all your questions.
Are we doing something tomorrow?
Yes, so tomorrow we are going to start with stomach tumors.
Okay.
And the same time unless there is something that is urgent that comes to me, I can also appoint someone else to be that while I'm doing the reading. So we'll probably take tomorrow.
Okay, I'll see you guys tomorrow then.
All right, thank you very much for joining.
Thank you.
You're welcome. Bye-bye.
Yeah, bye guys.
Bye. Thanks, Akanksha.
Yeah, bye. Thanks.
Thank you.
Thank you.
Thank you. Bye-bye.